Hi everybody, welcome to Dr. Manny's YouTube Learnshops. This is part 4 of invasive hemodynamic monitoring, where we look at pulmonary artery pressure. As with all the other Learnshops, they're intended for healthcare professionals such as you, nurses, or otherwise, who care for patients with pulmonary artery hemodynamic monitoring. And this will review some of the fundamentals. Okay, the learning objectives for this Learnship are a pre-knowledge review, which we always do, the indications, components, normal waveforms and anomalous waveforms, and the nursing considerations that you would think about when caring for a patient with a pulmonary artery catheter. So let's go through your knowledge review. Complications of a pulmonary artery catheter may include which of the following: peripheral limb ischemia, increased tissue perfusion, a stroke, or pulmonary lung ischemia. The correct answer is lung ischemia. The pulmonary artery is connected to which of the following heart chambers? The right atrium, left atrium, right ventricle, or left ventricle? The correct answer is the right ventricle. Which of the following apply to a pulmonary artery catheter? It's also known as a SWAN GANZ catheter, has a balloon attached, also measures right atrial pressure, or does it include all of the above? It includes all of the above. The dicrotic notch on a pulmonary artery pressure waveform represents which of the following? A, the pulmonic valve has opened, the pulmonic valve has closed. C, the aortic valve has opened, or D, the aortic valve has closed. The correct answer is the pulmonic valve is closed. Components of the flush system should include which of the following? A pressure bag, sterile normal saline, a flush valve in the transducer, or all of the above? The correct answer is all of the above. Which of the following are true of transducers used for pulmonary artery pressure monitoring? They've got to be aligned to the phlebostatic axis, they've got to be zeroed every day or as required, they must be primed to remove air, or are they all true? All the above are true. So, what is pulmonary artery pressure monitoring? Well, pulmonary artery pressure monitoring is monitoring of the pulmonary artery blood pressure via a catheter placed into a central vein so that the pressure in the pulmonary artery can be measured indirectly. This provides continuous measurement of the systolic, mean and the diastolic pulmonary artery pressures. What are the indications? The indications for pulmonary artery pressure monitoring are volume assessment, fluid and medication management, and during resuscitation. It can give you direct assessment to the right atrial pressure, the pulmonary artery pressure, systolic mean and diastolic, and it can indirectly assess the left ventricular end diastolic pressure. It can, which we won't be discussing, provide you with the opportunity to do cardiac output by thermodilution, and it's always used in critically ill patients. So pulmonary artery pressure monitoring is a form of invasive blood pressure monitoring and is done through the cannulation of a central vein. This form of monitoring is commonly utilised in the management of critically ill patients in an intensive care or an acute care area. What are some of the potential insertion sites? Well, as for a central venous catheter, the jugular vein, subclavian vein, antecubital vein, the basilic vein, the cephalic vein, and in some rare situations, the femoral vein. But the most common site of cannulation are the jugular and subclavian veins. Jugular vein and subclavian vein. What are the requirements? Well, the requirements are pressure bag, flush system, transducer, transducer manifold, a PAP catheter, pulmonary artery pressure catheter, a rigid and flexible tubing, hemodynamic monitor, and competent intensive care nurses. The pressure bag, well, as we've mentioned previously, it maintains a constant pressure of 300 millimeters of mercury to infuse sterile normal saline at approximately 3 mils an hour, and if it does that, it prevents blood from clotting in the pulmonary artery catheter. And it does this by a slow, continuous infusion of fluid into the catheter. The flush system itself is used as an indwelling PA catheter for continuous flush to keep the catheter conduit open. Remembering, intermittent manual flushing is typically unacceptable because of the danger of dislodging a small clot, an embolus, which could cause a pulmonary embolus, or the threat of bacterial contamination and the possibility of infusing too much fluid. The transducer is a device that changes a physiological signal into a recognisable pressure waveform, and in doing so provides continuous measurement of the pulmonary artery systolic, diastolic and mean arterial pressures. The transducer converts mechanical pressure into a kinetic energy, which can be viewed. The transducer manifold, this is when the transducer is placed into a manifold which is easily levelled to the phlebistatic axis. And the phlebistatic axis, as we've mentioned previously, is the fourth intercostal space along the mid-axillary line, and the phlebistatic axis is relevant for supine patients and up to about 45 degrees of the head up tilt. The pulmonary artery catheter, well, what is it? The pulmonary artery catheter is a thin hollow tube. It's 110 centimeters in length, and it's placed into a central vein, and then with a balloon at the end of it is floated into the pulmonary artery. And this provides a continuous measurement of the systolic, diastolic and mean arterial pulmonary pressure. It also allows blood sampling, and as we mentioned previously, it can measure cardiac output by thermodilution. And this catheter is often called the SWAN GANZ catheter in the intensive care unit. Why? It's named after two physicians, Dr. Jeremy SWAN and Dr. William GANZ, who initiated this catheter in approximately 1970. Well, there are numerous types of pulmonary artery catheters, but these are just some of them and their components. You've got the standard pulmonary artery catheter, which is a 4-lumen catheter. It's got a proximal port, a distal port. It's got a balloon port, and it's got a thermistor port. The tip of the catheter, the distal port, measures the pulmonary artery pressure. The proximal port measures the right atrial pressure. The balloon can be inflated to float the catheter into the correct position, and the thermistor port or wire is used for cardiac output studies by thermodilution. Again, looking at it, the thermistor port, thermodilution, the PA distal port, the tip of the catheter, the proximal injectate port is the right atrial infusion port, or it can be used for monitoring CVP. Some catheters have got an additional right atrial infusion port, which will typically be located in front of the proximal blue injectate port. But this is the standard catheter, which is typically 7.5 French and approximately 110 centimeters in length. And note, the balloon should never be inflated with more than 1.5 cc of air, otherwise it will rupture. There are markings on the catheter, and the catheter markings are typically narrow bands and wide bands. The narrow bands mean typically between these narrow bands it's 10 centimeters. So there you can see 3 narrow bands, 3 plus 3 plus 3, or 10 plus 10 plus 10 is 30 centimeters from the tip of the catheter. Then you've got wide bands, and the wide bands equal to 50 centimetres. So therefore we can see a wide band from the tip of the catheter, it's about halfway. Then at the end of the catheter you've got 100, and then right at the end of the catheter you've got 110 centimetres. Some of the variants, and these are just some of them for your interest that I've included. You can have a pacing catheter, so that you can pace via, you can have the catheter inserted into the right ventricle and they can do transvenous pacing. You've got one that measures the venous saturation. They still have all the other components, but they've got additional ones. So the standard lumens then, or ports if you want to call them that, are the yellow port, the distal port, is the lumen that ends at the tip. It opens at the tip of the catheter, which means it's 110 centimetres in length from that point. Then you've got the blue port, the proximal lumen, which opens 30 centimetres from the catheter, and if it's in the correct position, it will open in the right atrium. Then you've got the balloon port, and there's a syringe attached to that, and it's a special syringe, not any syringe. It's volume limited to 1.5 cc of air and shouldn't be taken off. And that inflates the balloon to allow flotation of the catheter into the correct place. Then you've got the thermistor, the white connector. Typically it has a red cap, which should always be kept there. And this is connected to the cardiac output cable, which measures core blood temperature in the pulmonary artery, but also allows for cardiac output studies to be done by thermodilution. You've also got other adjuncts. You've got the introducer, which is a sterile sleeve, and the pulmonary artery catheter is inserted through the sleeve prior to insertion, and it's the sleeve that keeps the exposed portion of the catheter sterile. This allows the catheter to be advanced, if required, for repositioning. Caution, number one. You've got to flush all the lumens pre-insertion. You don't want any air in the pulmonary artery catheter. The pulmonary artery catheter has got 2 to 3 lumens that must be flushed to remove the air prior to insertion of the catheter before it goes into the sleeve. And sterility of the entire catheter and its ports must be maintained. Caution number 2, check the balloon patency pre-insertion. You want to make sure that it's patent. And this is before insertion. Inflate the balloon with a small amount of air, or typically sterile saline. Check with leaks and confirm that the balloon inflates symmetrically. Note that the inflated balloon leaves a dimple at the tip to allow the pulmonary capillary wedge pressure or occlusion pressure to be measured during balloon inflation. You've got the transducer extension tubing, and it's approximately 48 inches in length. It's non-compressible rigid-walled tubing, and it's fluid-filled. Air is removed. It prevents damping and inaccurate transmission of a physiological mechanical pressure to the monitor. Then you've got the monitor. The monitor is commonly utilised in the management, as we said, of critically ill patients in an intensive care, but it requires personnel who are competent, and typically this will be competent intensive care nurses who identify normal and anomalous waveforms. Transducer alignment is similar to what we said before. Typically it will be in the supine position, level at the phlebistatic axis, which is the fourth intercostal space in the right mid-axillary line. The pulmonary artery catheter procedure. Well, insertion begins after all the catheter lumens have been flushed with sterile saline and syringes are attached to the yellow and blue ports. You've checked balloon integrity. The pulmonary artery catheter has been inserted into the sterile sleeve. The pulmonary artery catheter is then connected to the pressure monitor, and the transducer has been levelled and zeroed. Step 1 will involve the right atrium. So once the catheter has been advanced approximately 15 centimetres, the tip of the pulmonary artery catheter, the distal part, will be beyond the end of the introducer. The balloon can now be inflated, and if it is a right atrial pressure waveform, should be displayed on the monitor. The normal right atrial pressure waveform will have two distinct waves for every cardiac cycle if sinus rhythm, with a pressure that's usually about 0 to 8 millimeters of mercury. So if we look at the right atrial pressure waveform, it's typically an AV wave, which is a right atrial pressure wave. And it's typically between 0 to 8, 0 to 6, 0 to 8 we'll say here, under normal circumstances. Then step 2, the catheter and the right ventricle. As the catheter is advanced through the tricuspid valve, you'll see a right ventricular waveform, and it'll usually appear as about 20 to 25 centimetre mark on the PA catheter. The right ventricular waveform is taller due to the rise in the systolic right ventricular pressure when compared to the right atrial pressure. The right ventricular waveform consists of a large pressure wave, and it's got a symmetrical upward and a downward slope. Normal right ventricular systolic pressure is about 20 to 30 millimeters of mercury. So when you look at it, there's a systolic component and there's a diastolic component. The diastolic component is identical to the right atrial component, 0 to 8, but the systolic component will be much larger, 20 to approximately 30 millimeters of mercury. Then in step 3, you'll notice as the catheter is advanced through the pulmonary valve, you'll see a pulmonary artery waveform appear, and it's usually approximately 15 centimeters after the right ventricular waveform first appeared. And the systolic pulmonary artery pressure is about the same as the systolic right ventricular pressure, 20 to 30 millimeters of mercury, but the diastolic pressure is higher than the diastolic right ventricular pressure because of pulmonary valve closure. And this is the dicrotic notch that you'll see. The shape of the PA waveform is similar to that of an arterial systemic waveform, but the pressures are much lower because the pulmonary artery is in a lower pressure circulation, the pulmonary circulation. The PA waveform, as we said, systolic basically the same, 20 to 30 millimeters of mercury, and the diastolic about 8 to 15, higher than 0 to 8 from the right atrial waveform. In step 4, we want to measure the pulmonary wedge pressure, which is sometimes referred to as the pulmonary occlusion pressure. But as the catheter is advanced further, the balloon wedges or occludes in a branch of the pulmonary circulation that's about the same diameter as the balloon. And this will obstruct systolic blood flow towards the catheter, measuring only pressure in front of it or forward pressure from the tip of the catheter. The pulmonary wedge pressure is really an indirect measure of the left atrial pressure or the left ventricular end diastolic pressure, which is normally around about 8 to 12 millimeters of mercury. And once the pulmonary wedge pressure measurement has been identified, the balloon is typically deflated. You observe the return of the pulmonary artery waveform, as this confirms that it's able to pass around the catheter. Blood we're talking about. So blood can move around the catheter, making sure that there's no ischemia in the lung or potential ischemia. The pulmonary occlusion pressure or pulmonary wedge pressure is typically 8 to 12 millimeters of mercury, and it does have an AV wave. Step 5, on completion, the catheter is in the correct position. The balloon port should always be left unlocked in this position, except during intentional balloon inflation. When the red line between the port and the syringe is straight, the port is unlocked. The syringe is specifically designed to prevent overfilling and is limited to 1.5 ml of air, or 1.5 cc of air. It's always left unlocked because it doesn't want to be accidentally left inflated, because this could cause pulmonary ischemia and potential pulmonary infarction. Balloon is always left unlocked. So, what does a normal PA waveform look like? Well, it looks basically the same as your arterial waveform in the systemic circulation. And it represents the same things. But note, the pressure is much, much lower. Systolic, we said 20 to 30 millimeters of mercury. Diastolic, about 8 to 12. A lower pressure circulation under normal circumstances. We have the anacrotic wave, the first wave, and this is the ascending limb of the pulmonary artery pressure waveform. And as the pressure increases after the pulmonic valve opens, it reaches a peak pressure, which again is about 75% of stroke volume. The peak systolic pressure is the highest pulmonary artery pressure, and this is the force the heart exerts on the walls of the pulmonary artery each time it ejects blood, which is called the stroke volume. The dicrotic notch is the second wave, and this is the descending limb of the PA waveform as the pressure decreases after the pulmonic valve closes to the end diastolic pressure. However, during this phase, there's still 25% of stroke volume being ejected. This is the dicrotic limb, the second wave. The dicrotic notch, this is now when the pulmonic valve closes, and it defines the end of the pulmonary systole and the beginning of diastole. And as I said, it represents closing of the pulmonic valve. Then you have the end diastolic pressure, which is the lowest pulmonary artery pressure, and the end diastolic pressure is the lowest pressure in the pulmonary artery when the right heart is resting after right ventricular contraction. The end of diastolic pressure. The mean arterial blood pressure is the average pulmonary artery pressure, and during one cardiac cycle it's considered a better indicator of perfusion to the lungs than the peak systolic blood pressure. And it uses the same formula. The mean arterial blood pressure equals the systolic blood pressure plus 2 diastolic pressures divided by 3. Now let's look at some of the abnormal pulmonary artery pressure waveforms and their causes. Artifact, interference, could be again a problem that you're infusing fluid into the system, or it could be your electrical equipment is faulty, which means the bioengineer needs to be called. You can have catheter fling, absolutely, in a hyperdynamic circulation, or related to breathing. The catheter is in the lungs. Then you've got the PA, right ventricular catheter migration. So you may have retrograde migration of the catheter out of the pulmonary artery from the pulmonary valve back into the right ventricle. And there you'll see the right ventricular waveform. And that's potentially problematic as well, because apart from the fact that it's not giving you the information that you want, this can cause cardiac dysrhythmias, such as ventricular tachycardia, even ventricular fibrillation, irritating the right ventricle. Balloon overinflation, which means you've over-wedged it, which happens in the pulmonary artery. The catheter, the balloon, actually is in such a tight position, it herniates over the tip of the distal port and can cause this to happen. You've got underdamping. Underdamping when the waveform oscillations are too pronounced, and this can lead to a false high systolic or a false low diastolic. Causes, as previously mentioned with other monitoring systems, catheter whip, inflexible tubing, positioning of the catheter, or it could be transducer issues. You've got overdamping, when the waveform oscillations are slow, sluggish, and this can lead to a false low systolic or a false high diastolic. Causes could be loose connections, air bubbles, using flexible plastic tubing, too many stopcocks, transducer issues, overdamping. When you're troubleshooting the pressure waveform, again, we'll go over it again. You can use the square wave test, and the rationale for its use with PA lines, as with your other monitoring systems, are to test that your transducer isn't overdamping or underdamping. Performing the square wave test, when you pull the fast flush valve, you allow the pressure bag to deliver sterile normal saline to the transducer at a pressure of 300 millimeters of mercury very, very fast. And therefore this produces a square waveform that rises sharply, has a plateau, and then returns to the baseline sharply when the flush valve is released by you. Optimal damping, after a fast flush, there should only be 2 oscillations, and the height of the positive oscillation should be 1/3 or less of the previous oscillations. Cause? It just basically says the transducer is working correctly, and that what should happen is your data and readings should be correct. Then you've got underdamping. And underdamping, after a fast flush, there are too many oscillations. This could be as a result of incorrect tubing length, stopcocks, a high pulmonary vascular resistance, and this provides the wrong data and very high readings. Overdamping, 1 or no oscillations after the cessation of the flush, and this could be due to air, a clot, a kink, incorrect tubing, too many stopcocks breaking the system or open to the atmosphere, or as a consequence it provides the wrong data and low readings. So what are some of the nursing or care considerations that you think about when using a pulmonary artery catheter? What are some of the complications? Complications, your nursing considerations or care considerations should include preventing infection, observing for a hematoma, ensuring correct placement. Look at the chest X-ray Learnshop. Incorrect placement. Observe for pneumothorax post-insertion. So now let's review your knowledge. Question 1. Complications of a pulmonary artery catheter may include which of the following? Peripheral limb ischemia, increased tissue perfusion, a stroke, pulmonary lung ischemia. The correct answer is pulmonary lung ischemia and potential infarction. Question 2. The pulmonary artery catheter is connected to which of the following heart chambers? Right atrium, left ventricle, left ventricle. The correct answer is the right ventricle. Which of the following apply to a pulmonary artery catheter? It's also known as a SWAN GANZ catheter. It's got a balloon attached. It can measure right atrial pressure, or is it all of the above? The answer is, it's all of the above. The pulmonary artery pressure transducer can be disposable, measures a physiological pressure, is aligned to the phlebostatic axis, or is it all of the above? The correct answer is, it's all of the above. The dicrotic notch on a pulmonary artery pressure waveform represents which of the following? Pulmonic valve opened, pulmonic valves closed. Aortic valve opened, aortic valve closed. The correct answer is the pulmonic valve is closed. Components of the flush system should include which of the following? A pressure bag, sterile normal saline solution, a flush valve in the transducer, or all of the above? The correct answer is all of the above. Which of the following are true of transducers used for pulmonary artery pressure monitoring? They've got to be aligned to the phlebostatic axis. They should be zeroed every day or as required. They must be primed to remove air before you insert. All the above is true. The correct answer is all the above are true. Which of the following is true for the proximal lumen of the pulmonary artery catheter? You can use it for right atrial and CVP measurement. You can use it for cardiac output measurement by thermodilution. You can use it for giving vasoactive medications. Or all of them. The correct answer is all of the above are true. Which of the following relates to the pulmonary artery wedge pressure? It has an ACV wave, is normally 8 to 12 millimeters of mercury, reflects left atrial pressure or left ventricular end diastolic pressure, all of the above. The correct answer is all of the above. Which of the following are true of the standard SWAN GANZ catheter? It has a proximal lumen at the 30 centimeter mark, has a balloon inflation port, the distal lumen opens at the catheter tip. All of the above are true for a standard SWAN GANZ catheter. That's correct, D. Okay, thanks again. This is the end of Part 4 Pulmonary Artery Hemodynamic Monitoring. And as I've indicated previously, if you found this of any value, please recommend it to your colleagues. The objective is to learn. That's the objective of the Learnshops. See you in some of the other Learnshops. Bye for now.